So good afternoon, everyone, and thank you for joining us today for the second workshop for this rulemaking. I am Amelia Boyd, and I am the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime later this week. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. Attendees, please remain muted unless you are speaking. If you have a question, please use the raise hand function or put your question in the chat. And I will begin the roll call of staff and panelists. When I call your name, please introduce yourself. So first, go ahead, Marlon.
Good afternoon, everyone. My name is Marlon Basco, and I'm a policy analyst with the Department of Health, supporting Amelia with the rules.
Thank you. Dr. Curry.
Hi, Dr. Curry, OBGYN, medical commissioner.
Kyle.
Good afternoon, everybody. My name is Kyle Kiernan. I am the executive director for the Medical Commission.
And let me get Heather in here. Heather, if you could go ahead.
Yeah, this is Heather Carter, Assistant Attorney General, Legal Advisor to the Commission.
Thank you. Dr. Trescott.
Hi, I'm Claire Trescott. I'm family medicine and a commissioner.
Dr. Domino, please introduce yourself and then you may begin the script.
Hi, I'm Karen Domino. I'm chair of the Medical Commission. I'm also an anesthesiologist. And I will be the presiding officer for this rules workshop. Today is Monday, October 7th, 2024, and right now it is 2:44 p.m. The meeting is being held by a Teams webinar and in person at the Department of Health, room 166, located at 111 Israel Road, Southeast in Tumwater, Washington. The rule being discussed today is regarding the use of nitrous oxide in office-based surgical settings. And let me say this is pertinent to the Medical Commission, meaning it's relating to physicians providing use of nitrous oxide. And PAs, these are the people we
Dr. Domino, somehow you're muted.
Oh, sorry.
Oh, there you're back.
We will now, I had my finger sadly touched the key, so I'll keep it in my lap. We will now present and discuss the draft language. First, we will discuss the proposed section WAC 246-919-603. The proposed new section is included in the packet and will also be displayed on the screen. We will need to review each subsection, make suggestions for revisions, and then decide whether to vote to approve the revised subsection or postpone it for discussion at the next workshop. All right, Ms. Boyd, you have it on your screen. So I'm going to try to get rid of all these pictures to expand so I can see what's there. Yeah, thank you. Let's see if I can get rid of the yes. Would you like to introduce things?
Sure. So we will go through this new section, which is 246-919-603. And we will go through by numbered paragraphs. And then I would like for the commissioners and then anyone else who's here who would like to discuss it. And then we can make revisions based on that discussion. Or if you like the way it is, you can go ahead and vote on how it is right now and then move to the next numbered paragraph. We're just going to go through it that way in this particular workshop. So right now we're dealing with paragraph number 1.
Great. So you can see the reason why we have this rule and why we're the proposed rule. And what we're trying to do is to echo what has been existing for the dentists and that. So a lot of this is patterned after what they've done before. So I don't know if you want to pull it down. Amelia, do we just have people read it themselves? Or do I have to read it, or how do we want to deal with this?
No, I think they can read it themselves. Since it's up on the screen, I'm sharing my screen with everyone, so they should be able to see it. And if anybody
Yeah,
has
you-
any comments,
Paragraph 1 looks good to me.
Yeah, can you scroll down further?
Yeah, it looks good.
And is that the end of page?
so right now we're just dealing with this little paragraph right here.
Oh, that paragraph. Oh, okay,
Yeah.
fine.
Just that number
Um,
paragraph number 1.
That looks fine to me as well. Is there any discussion of this paragraph?
Not for me.
Okay, can we vote on that, Amelia? Is that what we should do, the three of us,
Yep,
commissioners?
as long as you vote to pass it through. Yep.
Okay. Well, all the three commissioners of us, many in favor of approving this paragraph? Say aye or
Yes.
raise your hand. Okay,
Aye.
there are three of us. We approve that paragraph.
Okay, moving on to paragraph 2, which is a little long. So you may only be able to see like the first part of sub C. So we'll look at this, and if you have any changes to what's on the screen, and then we'll move down further into that particular paragraph.
Karen, could we have the clarification of this other WAC, the 601, 246-919, 601?
Yes,
What are we going to be exempt from?
That is the
So that one's also
safe
in the
and
packet.
effective analgesia and in anesthesia administration in office-based surgical settings. And we will be, they have something here relating to a few changes relating to the requirements in this one related to nitrous oxide.
Okay, thanks.
So I think, from what I recall, the history, someone just said, why does it go to C to I? I think it's a 1, isn't it not? Or what? Or little,
Right, so
it's
yeah, there'll be a small Roman number 2. So it'll be little II on the next page, but this is all we can see right now.
So far, this looks fine to me.
there are all these people coming in teams and they come on in 1 second and then they're gone. Amelia, do you want to deal with that? Or do we
Sure.
just leave it for the discussion period of time?
Well, they want to talk about section CI, which we do have up on the screen. They're asking, what about procedures where a nurse or PA is performing the procedure? It only refers to physician. I am thinking about IUD insertions, for example. So first off, we don't have authority over nurses. As far as a physician assistant, we don't have these particular rules in our PA WAC. So
Amelia,
just
this
with
is
that.
Diana.
Sure.
Can
Sure.
I
Yeah.
ask? My understanding was we do this for the physicians, and then if we want, we can then extend it later to physician assistants, kind of like paralleling it like we do with other, or no?
We can do that. We have not established this in the PA WAC
Okay.
currently, but we've had
And then-
this OBS, the 601 section has been in place for many years for physicians.
Right. And so I
And-
think there
and-
was a lot of comments about nurses and ARMPs and things like that. And the thing is, like, they certainly should pass their own version because we would
Sure.
love to see it expanded to that, but we just don't have any say in that, which I think there was
Right.
confusion in a lot of the comments around that, which I know Karen, you tried to clarify, but maybe it's worth stating a second or third
I
time.
think it probably is worth saying more about it. Thank you, Diana. I think people don't understand that who we have jurisdiction over, and you have to approach the nursing commission regarding doing these kind of changes. All right, well, I thought these were fine. Where there's some other, I see comment flashed on and I didn't get it.
It just says, thank you, that is helpful.
Okay, good.
So if you're good
All
for
right.
what's on the screen, we can, oh, did someone have a comment? Okay, maybe not. If you're good with what's on the screen, we can move on to the next part of this same paragraph. I'm going to scroll down. Just be aware. Yes, number 2 is very long. And this addition is a request from the last workshop that we add in some more information about what the healthcare practitioner that's present has to be certified in.
There's a question whether the dentists have ACLS,
Yeah, I was wondering that too.
but we don't
I think
regulate
they
them
have-
either.
Right. So the
Yeah.
dental has their own commission. So I can go look, but I would assume so. Heather, if you are here, Heather's also
I'm here,
the
but yeah, I can look, but I don't know off the top of my head.
okay.
I think
I think they have something similar.
one of the comments we received, I think Amelia, what somebody said they only have BLS. And so why are we wanting to have ACLS for our group that we regulate? I don't know if there's any public members out there wanting to comment, but that was one of the comments I read. And
I think
didn't check dental. Yeah.
Yeah, I think from the last meeting, people wanted to see this for safety reasons. Many physicians do have ACLS certification. Not all, though. I mean, if you're going to use it as a gynecologist or urologist, which may be the most frequent areas, you may not have that. But that's why it got put in there.
Yeah, I agree. And I think that most practice, so as a GYN, I think not every GYN has ACLS, but many, many do. And this does say that at least one person, so presumably it doesn't have to be the person doing the procedure. It could be someone helping monitor or in the practice. I'm not sure we're requiring every person who's using it as for their procedure to have it.
No, it's
That's
just,
my reading.
yes,
Yeah.
one person
Available.
available.
And, this would be consistent with conscious sedation with other meds too, that ACLS is a component of qualifying. I don't know if it's a WAC. It can be a common rule.
Yeah, so is there another comment about this, Amelia?
So I will just address the comment. So one of them says if licensed midwives have their own WAC and have it in their legend drugs and devices, they are not affected by this. Correct. So all of the rules we're talking about today are only affecting allopathic physicians. So an MD, not even a DO, an osteopathic physician. So these rules only affect them. And then one of the other comments was you started saying that this was mirroring dental. So not technically, we took some language from dental's WAC and put it in here, but not all of this mirrors what dental has. So, and then they stated that they think ACLS is excessive. And then to need all those supplies and a crash cart in the office, but it is self-administered and so not as deep as conscious sedation was the rest of their comment.
Yeah, I think, this is something people may not agree about, but there was a feeling of having more safety involved. These are outpatient settings. They aren't a hospital on an OB floor, as an example, where you have people an ability to resuscitate people. Yes, it would be extremely unlikely to have any problem. However, it is it was asked to include due to safety concerns. Doing the ACLS, it's not a huge deal to do. And it's not every year. And you only need one person or whatever to do that. So we wanted to make it safe.
You know, the crash cart brings up an issue about ACLS. I don't know how many people who use it in outpatient setting, like a gynecologist or whatever, would you have a crash cart in all your clinics, Diana?
Sorry, couldn't find my mute. No, so we did talk about that last time. Typically, you would not. So, nor would you necessarily have oxygen, even necessarily a portable oxygen tank. So I think we had talked last time about maybe considering having some of those safety features in the office. Who wants to begin doing doing nitrous oxide? So that was, yeah. So that's a question. I mean, if people don't think it's necessary, I kind of thought it was, but
I mean, I like the safety of it.
Yeah.
And I think if you're going to use nitrous oxide, that you're probably going to be willing to take a extra course to do it.
Yeah, I mean, I didn't feel it was necessary at first, but I think I like the safety aspect of it, so I've changed my opinion. I think it's fine.
So additional comments from the chat is dentists only have BLS was one of the comments. And then this comment is the idea is that nitrous under 50% is minimal sedation and categorized as such. If the concern is the safety and the need for ACLS/PALS and a crash cart, perhaps nitrous at any level should not be categorized as minimal sedation. Do other methods of minimal sedation, oral or otherwise, have the requirement for ACLS/PALS and a crash cart?
I don't know if anyone has an answer for that. I mean, I think it is, let me just say, as an anesthesiologist, you know, if you get someone who's 80 years old and having a procedure, that 50% nitrous may be enough to make them sedated, very sleepy and unresponsive. Yes, well, they may drop their mask, but if it's hooked on them, we just wanted to build, you know, this is a change. This has not been allowed before unless you are an office-based surgery practice. And the ask was to try to come up with something that doesn't have to have all the rules and regulations that office-based surgery does. So you know, that's why it got stuck in there. I don't know.
I mean, it's true that BLS would cover you. I don't know, as a physician, I kind of feel like you take more responsibility, or you have more responsibility to be able to go beyond BLS.
Well, I agree with that as well. I mean, it's not a huge ordeal if you want to do this.
So maybe I'll just, if it's okay, I'll play devil's advocate for 1 second with you guys, which is that if I'm ACLS certified, fine, which I always was because you often have to be for medical staff, the number of times I ever actually had to use my ACLS training was incredibly rare. And you know, you could potentially go a few years when you're a sort of outpatient or a general gynecologist, say. So how effective would we be? I mean, in some ways, now I'm thinking, I don't know, maybe BLS is enough and having oxygen and less than a whole crash cart. Um, I mean, it's true, we do lots of things with, you know, some opiates and Advil and things like that, oral sedation. You know, we pre-medicate patients before procedures. I mean, have I called 911 from the office? Many, many times. People vagal and pass out and fall off the tables and weird things all the time. Not all the time, but it does happen. So I don't know. I don't want to make a barrier for this to be used. So I don't know. What are you guys' thoughts?
Actually, you bring up a good point that if you aren't using it, and actually in places where I believe it's really effective, we would have drills where we would do ACLS stuff to keep in practice. And I would say in family medicine or urgent care, it's not unusual to need your ACLS skills. So this is a hard one. In some ways, I don't think we should expect people to have ACLS and be very good at it if you use it once in 5 years.
There are tons of these things that come on for 1 second, so I can't deal with any of those. I mean, Diana, this was put in, I think, probably because of your request. And I mean, the one thing about use of nitrous oxide is generally in offices that do this around the country, they do not give other sedatives to the patients, because when you're doing that, and especially in the elderly population, you're going to change from sedation to general anesthetic. Okay, and so I don't think we necessarily, I don't know what we wrote into this at this point, but that's why I think people are going to mix and max drugs and provide an anesthetic without having an anesthesia provider there. They need to have some skill, like how do you handle an airway with airway obstruction as an example? How do you ventilate
Right.
someone?
Right. So, Karen, I think you're right. I think I was concerned because I think that I thought that all practices that used this had ACLS as a requirement. So in my mind, I thought that if we were going to have ACLS as a requirement, then you got to have the crash cart and all the equipment. Like there's no point having ACLS training if you don't have any equipment. If we say that you don't need ACLS and you just need BLS, and that we have a long record of, say, the dentists using this in peds patients as well as elderly patients, et cetera, and not having problems, then maybe we remove the ACLS requirement, make it BLS, and then have, I think my understanding is if you just have a good supply of oxygen, you can really quickly reverse the nitrous oxide. Is that?
Well, if they're breathing, but if you're giving
well,
other sedatives,
but we're
and
not
then
supposed
they
to
may
give
not.
other.
Yeah.
Right, but isn't it against this rule to give others? So if you were going to use nitrous, you can't give opiates or anxiolytics or anything. You could give Advil, from what I understood, say, some pre-medication with, not naproxen or something, but not opiates, not anxiolytics, benzos,
Yeah,
etc.
I kind of like the idea of having guardrails like that about whether other medications can be used, rather than having the ACLS PALs. I am surprised that said that midwives would not be able to fulfill. Don't most midwives have some PALs training? I'm just surprised.
Yes, yes. Hospital-based midwives will have ACLS probably and PALS, or
Okay.
yeah, I would think, yeah.
So I'll read these comments real quick. Because I know
just want
Karen
to say
can't see them. So.
I just going to say I've kind of changed my mind and don't think we should have it in there. If we're worried about mixing meds, we should put down don't mix meds in some form, and give the parameters of safely using nitrous.
I think it's in there that you can't give those other classes of meds, Claire.
I thought we wrote it in there, but I don't actually see it, but we'll see if they do.
I think it's the
in
definition of
2B.
minimal. Yeah.
Mm-hmm. Do you want me to read these comments real quick?
Sure.
Yeah.
Okay. So the first one is sedation is on a continuum, and while the intent is that 50% nitrous is to be considered minimal sedation, patients respond differently and may enter into a higher level of sedation. And then Dr. Trescott referenced this comment that said, "You are setting a precedent that midwives will not be able to fulfill." And then the last comment says, "I have been an active OBGYN practice for 28 years and have never used ACLS, have never called 911 from my office except when someone is in active labor." So those are the comments that have come through since the last time I read them. So are you wanting to change A to BLS then?
That would be my tendency, is to just to.
I'm fine to go
BLS.
back the way we had it before. So that's BL.
I didn't know we
BLS.
had it in that before,
Did
but
we
yeah,
not? Maybe we didn't have
I
it. We
think
just
I think
referenced
we,
it. Yeah.
yeah, I think we didn't, which is why I was thinking last time we had to have a crash cart, et cetera. But if we're allowed to take that out, because I guess I didn't realize that was optional, then I would change it to BLS, I think. Make a little bit less of a barrier for people to use this.
So Karen, you're our expert. Could you live with that?
It wasn't in there before, so I'm fine. It's the mixing and matching drugs that's a problem, and there's a problem in elderly people, and the biggest problem is rescuing patient from deep sedation levels, meaning being able to ventilate. It's a BLS, basic life support skill.
Yeah, BLS should help with some of the airway stuff.
Yeah.
This is Heather. So your provision right now and where that change is going to be, do you want the physician to be BLS certified? Because I think you can just put that instead of saying at least one healthcare practitioner. I think you just want to add in the physician must be hold BLS.
Well, if they're doing a procedure,
That
they
sounds
may
good.
need someone else to help. Right? So I'm not sure they have to be.
Let me go back up so we can.
Demonstrate competence. We could just have be BLS certified.
I think
In this,
the physician,
go ahead, Dr. Curry.
no, I think the physician should be BLS certified, and it would be helpful if somebody else who's like helping monitor the patient also is. I think most people are, but you know, if you're in the middle of a procedure, you're doing, say, a LEAP procedure, and you've got a lot of bleeding from the cervix, and the patient starts to have a problem, you actually can't leave your part of the procedure to help deal with the patient's respiratory distress, say. So there was a part of this that talked about having a separate person monitoring, and it could be, you know, your MA even, I don't know. But what do you guys think for safety reasons?
I think it wouldn't hurt to have the physician plus those supporting the patient must be the BLS.
Yeah, I
don't
think
it's a
it
big-
should have all those.
So what I'm hearing is that we're going to defer this one for some work, right? This paragraph 2.
Yeah.
Sorry, Amelia.
No. That
And I
is
have
the
to say-
purpose of these workshops.
I have to say, sorry to the midwives, you would be under nursing, I think, more than us. I don't know, do they
Yeah, I
have a
think they-
similar?
They have their own, I don't think they're under nursing actually, are they?
Oh,
Well, there are separate types of midwives. There are the
Mhm.
nurse midwives, and then there's the other midwives that have their own their secretary profession, I think.
Yeah. So, okay, so we're going to rework this, but we can still talk about the rest of this paragraph. Are you okay with B and C above?
Well, that's
they're all coming
Are we
out.
advanced
eliminating
life
all of
support,
this?
so we'd be eliminating that. ACLS
Okay.
covers basic PED support too.
Got it. Okay. So moving on to little Roman numeral 3.
That seems reasonable.
I agree.
Yeah, those are fine.
So there's a comment in the chat that says, do we need to defer or just put in BLS and that at least one support person also must be BLS? Well, what we'll do is if we have time at the end, we'll come back to that particular piece. And if we don't have time, then we'll just defer it for another workshop.
Yeah.
Okay, now what
Between-
about,
You guys, oh, sorry.
go ahead.
I have a confusion on 4 and 5. The physician
Mhm.
performing the procedure must not administer nitrous oxide or monitor the patient, and then the physician administering nitrous oxide must continuously monitor the patient throughout the duration of his administration. So in a typical office setting, you wouldn't have 2 physicians in the room, right, with the patient. You'd have
I think
one.
there's a word missing or something, because the
Yeah.
idea was to have someone, the physician direct someone in the office who's capable to
Yes.
continuously monitor nitrous oxide and the patient. And to
Right.
keep an anesthetic record.
Yeah, so we want to imagine that there's a MA or an LVN or somebody
Or a
who's
nurse.
somebody's administering and can communicate with the physician what the vital signs are being monitored and what's happening and all of that. But the physician themselves may not be administering and monitoring
Right.
directly. They would be indirectly monitoring by somebody else who's looking at the blood pressure and all that. I think it's just not quite
Yes.
clear here.
So
Well, I think
should,
the 5 is it's that's where I think you should clarify it. We did want to say they can't do the procedure and administer nitrous oxide or monitor the patient. They need another person to monitor the patient. So you could change 5 to saying the patient must be continuously monitored throughout the duration of the nitrous oxide administration.
by someone other than the physician performing the procedure.
Yeah.
You could put it all in one blurb.
so we can't, I don't know that we can do that though, because we're directing a physician in 5. If we're directing anyone else, I don't know that we can do that.
Oh, I see. That's probably why it got there.
So you
Mhm.
could say something
What
like the
can't we-
physician should ensure that the patient is continuously monitored by another licensed provider.
That's good.
Yeah.
I
Thank
think-
you, Heather.
I think this for saying physicians must not, or the ones that must not monitor the patient. I think it's better to have more positive, that at least 2 staff will be involved, or at least 2 healthcare providers will be involved. And the physician performing the procedure has to be supported. I don't know.
Okay, I'm gonna need Heather to repeat what she said.
I think just
Sorry.
add
I
to
think you got that.
the end by another licensed healthcare provider, or by another, I don't know if you have a better term for healthcare provider, but it
I
could
think we
be
just
a lot
say-
of different.
By a
Yeah.
separate healthcare provider. Something.
A separate, is that what you said, Dr. Curry?
Yeah, what is that? Does that sound okay?
I mean,
Make it
I
clear.
can wordsmith it better. Why
Isn't it another adequate?
What's that, Dr. Domino?
I thought what Heather said about another is, I mean, isn't another meaning that's a different person?
Yeah, that's fine too. Whatever. It's just to make it clear, it's 2 different people.
I'll rework it to where it sounds better.
There are a number of comments that seem to be floating past.
Yeah, this language is, I think that the word provider often is how we refer to physicians. So I think maybe a different word for that would be helpful.
Provider is broad, not just a physician.
No, it isn't, but it's in a language. In administrative language, they're called providers, and the nurses aren't called the same. There just has to be someone else. Another member of the staff, whatever.
And I can look and see what kind of language we use in the other sections of our rule for sure. I think we say practitioner actually. So I'll have to take a look and see, make it consistent.
Do we want to use Heather's language of a licensed person? So that because
Yes.
MAs, LVNs,
Yes.
RNs, they're all licensed. So I think
That's good.
that was a nice addition.
Yeah, I like that too.
So you want it to say by a separate
Yes.
licensed health, a different licensed healthcare provider?
Another, yeah.
Another
Oh,
separate.
Another individual who is
Another
licensed.
licensed provider or practitioner or something. Licensed, yeah. Or we could say person if we don't want to use provider and be confusing because people think of providers as doctors, as MDs.
Well, like I said, I'll go and see what else, what
Yeah.
other language we use throughout the rest of the WAC to see. I just want to keep it consistent, but I'll take a look at that one. Okay, now that we've butchered 5, did we have anything to add to 4
No,
or 3?
no.
Looks good.
Yeah, I think they look good.
Okay, so here's 6. And there was some question at the last one about that statement, including arrangements for emergency medical services and appropriate escort of the patient to the hospital. That is directly from our other WAC about office-based surgeries that we'll talk about a little later. But that's where that language was lifted from.
Was that requested by someone like Diana?
No, but that's where I lifted it from. There was some
Okay.
question about where that language came from. And so I just wanted to make that note in here since it was brought up the last time.
Sure, that sounds fine to me.
Is that gonna, can I just ask, is that gonna be interpreted as somebody from the practitioner's office, the practice, has to go with the patient to the hospital? Because
Yes.
that might not be possible
Well, they
in all
could leave.
cases.
Yeah, I mean,
Yeah, okay. Do we want to make sure, have that? Is that normal for other
No,
practices, or do you just call 911 and pass them off to the EMTs and?
yeah, it's actually more appropriate for the EMTs to take the patient and have the responsibility for the patient during transport. So I don't think that the office-based staff should be escorting the patient to the hospital. If they need emergency care at
Yeah.
that moment, they need EMTs.
I agree. So appropriate escort would be interpreted as the EMTs, not somebody from the office. I just want to, because I could see where that would be potentially like a point of confusion. So I just want to be clear.
Right,
So just
Dan, and
keep
there's
in mind-
something about the language that kind of says you've got to drive them yourself.
Well, just keep in mind that this language has been established for about 7 years in that other WAC, and we haven't had any calls about that particular piece. So,
Oh, that's
Okay,
good.
that sounds good. I just wanted to bring it up. Thanks.
Mhm. Okay, I'm going to make a little note. Someone in the comments had a good way to phrase this, so I'm just going to make a little note here real quick, if this will let me. So that I can come back to that. Okay. So are we okay with 6 then?
Yes, for me.
Oh,
Yes.
we have a hand raised. Go ahead, Billy.
Hi, good afternoon. This is Billy Dickinson with the Washington State Medical Association. I just wanted on that about this separate provider being in there. Is the intent that that's like an MA, an RN, LPN? Is that kind of what we're thinking there?
Yes,
Yes.
we wanted somebody to watch out for the patient other than those involved in the procedure.
Okay,
The
but
reason why I use
not
the word
specific.
provider, you can look up a better thing, is provider to me is all sorts of people, right? So that's
Okay,
why.
I just wanted to clarify there. Thank
Yeah.
you.
Thank you, Billy. Okay, so we're good with 6 now that we've explained it. Great.
Why was 6 added? I mean, why was that added? Was that a comment from before or just?
No, it was already in the language that we presented at the last meeting. There was just a question about where this language came from, and I promised that I would
see.
look it up, and it came out of, that's why that note's in there.
Okay, thank you. Okay, so
Take that note.
are we agreed on those things? We can move on to the next.
Yes, ma'am.
Okay, moving on to very long 7.
I have a question about D. Karen, this is
Okay.
kind of for you.
I'm not sure
I-
why that's there, other than we took it from things. They do need a history and physical and that. I mean, I think they maybe need an airway exam or something.
So I wanted to ask if pre-anesthesia evaluation includes like open your mouth and let me look at your airway. I didn't know if that was like
Yes.
had a specific, okay, so that's like not something that I would ever have a clue what to do. So I don't know if that should be there. Again, if we're not
Was this in
planning
the
to intubate.
dental rules? I don't know if.
Yeah.
I don't think so. I'm trying to figure out. It was in the last iteration of this language, so I would have to go back and check and see where we picked that up from. It might be in 601. Let me go look.
I think that's a bit much. Because you could say, well, after a certain age, they have to have an EKG, they have to have.
No, I
internal
don't think
study.
that wasn't the intent. I think we were just, open your mouth and look at the airway. Right? There are people who may not be a good candidate for this. Particularly
better if they
morbidly
have-
obese people with many comorbidities.
I think it might be better to say, before the mouth is or airway is evaluated prior to the procedure, just to say what we expect to happen, rather than pre-anesthesia, which is vague.
Right. So that's definitely not something like I would know how to do. I
Right.
barely understand like ASA 1, 2, and 3. Like I kind of get the gist, but that's kind of beyond the scope, I would say, for a lot of the people that might be using this, urologists, GYN. Certainly comorbidities, like obesity, hypertension, all kinds of stuff. Like I would look at that patient and think they aren't safe for the office. But that's not a formal pre-anesthesia sort of checklist points off for each of those things you classify as ASA 3, 4, you're not appropriate, like that type of formal approach. So that's why I don't know that I even looked at this last time or like realized it quite, but I wanted to ask Karen about that. Yeah.
Well, I don't recall it being there either, but that was a long time ago. I thought we were trying to mirror what was, I know people objected to the word mirror because there are differences, but we were trying to use some of the language that was in dental as well as meshing with some of our own language in office-based practice. So maybe that's
Which
where
is
that
what
came up. That's probably
definitely
from
where it came
office
from.
space. Yeah, so I
Yeah.
get rid of that. I agree.
Okay.
You think it's
So
okay to just get rid of 4 or whatever that is, D?
D, yeah.
just D?
Yeah.
Okay. Because someone
I
said
mean, we don't care the lab. I mean, we don't care about those necessarily either, but that's just, I mean, they're basically asking for a more than a sentence saying, hi, someone's especially the urology cases. Many of those folks are old and sick, and it's good to know their comorbidities. Now, one should learn history and physical diagnosis and plan.
So someone in the comments said that I think H&P is enough. Just to let you know.
Well, I don't care about, I mean, the labs, I'm not sure that's necessarily, I think it was just, again, taken from the office-based thing.
Right. A lot of procedure notes that you use for office-based procedures, though, will have things like labs or path reports. It's sort of part of the indication for that procedure. So I would always include like the ultrasound report and the biopsy that I did, and all of that for why I'm doing an office hysteroscopy D&C, for example. So I think that's
mean,
kind of part of the
yeah.
H&P, but it's also part of like a standard note that you would write. Even like for reimbursement on an office procedure, you would generally include a lot of those elements.
I mean, so if it's an IUD, you may not need anything, right? So it says appropriate. It
Right.
doesn't say you have to have anything. It just
Exactly.
allows people to put in what they want.
Yeah, no, that's a good point.
Yeah, I was thinking about actually using this for lacerations that you're repairing. And going much beyond just how did the laceration happen. I don't know, it seemed like a lot. If it doesn't have to be done on everyone, then I think it's okay.
Right. But if
Well,
it was
you
like
always verify identity. You always say 2 sentences about the history and the physical, the diagnosis, right? And then if there's anything else you wish to include, I mean, it was copied. I don't think it's essential, but if you are going to do it, then maybe you might want to include that, right? You don't have to.
I think keep it in the number C, because like Karen, Claire, if you had a deep laceration with glass or something, you would probably get an X-ray or something to make sure there's not glass embedded deeper, and you'd want to put that in your notes so that you don't get later, faulted for not having checked or whatever, right?
Right, or checks for tendons or other things that could be complicating.
Yeah.
I think it's good.
It kind of
This point.
strikes me that is good medicine, but D felt like it was overkill or beyond necessary.
So there's some comments that say instead of pre-anesthesia, it should be pre-sedation.
Isn't that part of
What's
the other?
Yeah, what's that difference? What's that mean specifically?
It may be your NPO status thing.
So you just want to eliminate it or change pre-anesthesia to pre-sedation?
I don't want to do that.
I wouldn't. I think we're in saying history, physical diagnosis plan. I think that would be okay.
Okay. And then we have another comment that says pre-sedation and post-sedation scores would be helpful to protect the provider. It will allow documentation of the return to baseline sedation level noted at the pre-sedation evaluation, NPO and baseline level of sedation to allow documentation of post-sedation level.
What kind of scoring is this?
So
I
the
don't
person who
sure what the
commented,
score.
sorry, does
Go
the
ahead.
person who commented want to go ahead and speak? You're free to speak. D. Bender, if you'd like.
Yeah, sorry. So for just basic nurses, when you're doing different types of conscious sedation and things in the hospital, you're assisting a physician with conscious sedation, minimal sedation. There are already established sedation scoring mechanisms that are available that you could use. I just think it would be helpful for the providers in office-based settings in order to have those type of scores so that it shows that they did their due diligence in bringing the patient back out before they dismissed them. That's the intent anyway, that this is minimal sedation. And so that allows them to document that they did so. It's just another layer of protective mechanism, just like having two providers there, one that's monitoring it, monitoring the patient, the vital signs, their oxygenation and so forth. Then that person would also be responsible for documenting that the patient has now returned back to a baseline sedation level.
Diana has her hand up.
Yep, go ahead.
So I thought that, thank you for saying that. That was well put. Question, is that pre-sedation scoring system, because there was also a comment we received about that, the return to baseline and like they're appropriate for discharge from the office, et cetera. Is that something somebody's going to learn in the nitrous oxide CME? Because that isn't something that's like I'm familiar with. I think that is very much a nursing function, like in a pre-op or post-op area. But since we regulate physicians, just thinking as a physician, I'd be like, oh, someone needs to teach me that. So does anyone know if that's in the CME?
I don't, but since I don't know if it's in the CME, but I do think that asking physicians to learn some new scoring process is a barrier to this, and making sure that it's done or recorded a certain way. It gives them more steps to take this to the office.
I'm fine with just having appropriate pre-sedation evaluation and leading it as a rule with not a lot of detail. I mean, or say including return to baseline. I don't know if we have that. I mean, yeah.
Isn't the main thing that the patient is evaluated post-procedure
Yeah,
to be
it
appropriate
is.
for discharge? I mean,
Right, that's the big
big
thing.
And I think that's in there somewhere. I remember reading it later on, maybe.
All right, well, we can scratch that, right? So can we move on?
I'm good.
So we're eliminating D for sure.
Yeah.
Okay,
Yes.
and moving
Yes,
on.
thanks.
Okay. So are you fine with new D and new E?
Yeah.
Yes.
Okay.
Yes.
Then little Roman numeral 8 is all about the equipment. So there was an ask at the last workshop, the first workshop, to speak to the equipment and like the care of the equipment. And so I went and pulled from dental's rule what is in 8 here.
Yeah, and I thought the equipment is important.
Does this look adequate, Karen? Does this look like it fulfills what we were wanting before? It does to me, but I feel like you're the
I
expert.
thought it did. I mean, there's equipment or the monitoring. We already have that. I thought it looked good to me.
Yeah, it did to me.
I think it looks good.
So we can move on to 9 then. So this was an ask, and I have a note. I'm glad Billy's here. I have a note that Billy, you were going to reach out to your members for an age cutoff for pediatric patients. I did pull everything that's in 9 directly from our other WAC, which is about sedation in dental offices, I believe, which is 602. And I can pull that up if you'd like to read it, but I did pull that directly from there. And in that one, it says is younger than 6 years old. So I don't know if Billy,
Well,
I don't
that
know if
says
you're,
risks. The
Yeah.
problem is that, if we were looking at the dental rules, babies and don't have teeth, and they often don't even come for nitrous oxide until they're older. I don't know what age per se that is. So those, you know, those, we don't want people doing this on neonates, right? You know, it's just not
Right.
appropriate. And that's
think
why I
WSMA
maybe said you should talk to the pediatric anesthesiology group at Seattle Children's to find out things about it. So did WSMA talk to anybody?
WSMA said 1-year-old should not be used in under 1-year-old. I believe that's what Billy's note test said, right?
Yes, this Billy. Yeah, that's what we said. I spoke with Dr. Bridget Bush and Dr. Bromhall, who are both on our executive committee. They're anesthesiologists, and the 1-year-old was where they landed.
Do we have that listed there somewhere? These are special rules. Someone has some other comment as well. Okay.
So are
Yeah,
we saying,
that
come back to
seems
that
fine.
comment.
But younger than 6, I mean, really, you know, the issue is that depending on the procedure, many of these, frankly, from a national level, most of these things are used in GYN and urology patients. Kids have a higher anesthetic requirement. They can also get wild. There are IV issues, other stuff with them. I mean, I thought this seemed fine. I'm not sure I want to put an age. You could add in older than 1 or something, but there's special needs, airway. I mean, they have a lot of stuff.
So everything like A, B, C, and D are all related to this, which is a discussion with a parent or guardian out of a pediatric patient.
Yes.
So there's a comment that says, I worry about this requirement for patients who may be getting birth control. So
Well,
does that
it's
mean
a
like
pediatric
teenagers?
patient is under 6, I thought.
well, in hospital admissions as to adult hospitals taking in younger people, some people cut it off at 18 and some cut it off at 14. So when are you not a pediatric patient
Mhm.
and when are you?
But this
They're
rule is saying
emancipated
particular
minors,
risks.
right?
Right. This
Right.
rule is saying people have particular risks if they're younger than 6. So if they're over 6, which anybody with birth control is going to be, this particular rule 9 or paragraph 9 wouldn't apply, is my understanding.
That was my understanding too.
So I think
Mhm.
that's not a concern. Do we need to say in here, though, just to include what WSMA recommended, somewhere also say it should never be administered in under 1 years old?
I like the idea of taking neonates and infants out of this. I don't know, Karen, can
Yeah,
you?
we have to remove them from it. It was just an oversight from before. I don't know where that goes though.
Amelia, are we allowed to add?
Absolutely. I mean, you can certainly add.
And I'll get more input
So
beyond just John, who's a colleague of mine who does mostly adults, and the other person. So I just want to run it past the pediatric anesthesiologist as well later on, since no
and
one's
so
here. Yeah,
you want to add in, I
it
don't know.
should. I don't know where it goes, but it should somewhere up earlier. It should.
Yeah.
We should exclude children age
Okay.
1 and under.
Age 1 and under. Got it. Let me just make a note.
And we might, with a little comment that we have to look at that beyond a few people.
Karen, you mentioned some adverse reactions that kids can have or change in dosage that they need and
Oh, I said
can
that
have the
they
opposite
need higher
reaction.
requirement if they can get wild. Yeah, because they don't have enough. I don't know what the dental rules, what do they, I mean, they don't, again, they don't deal with kids without teeth, so. And kids, even I have a grandson who's a year old, he has one tooth, right? So they don't see kids those ages.
Yeah, probably not till 4 or something,
Yeah.
maybe 5, I don't know. I also would say that, I mean, did a fellowship in pediatric gynecology, and I personally would never do a procedure on a little girl in the office because it's so traumatic. Even with nitrous, it would be traumatic, I think. And it's
Yeah.
kind of a rule of thumb that we don't traumatize children,
They're
especially.
not going to be as sedated as an
Yeah.
old person. Okay, that's part of the issue.
Well, I'm wondering if that type of comment should be in the rules somewhere about the difference with using this in children.
Though you would think anybody that takes care of children would know that, wouldn't they? Or I
They
don't
would
know,
know
maybe not.
they may have the opposite reaction to a sedating med.
Yeah. Yeah.
There's a comment with a hand.
Yeah,
RK.
there's a hand raised. I was just waiting for you guys to finish. Rachel, you can go ahead.
Yeah, hi, this is Rachel Kinsey, working with Planned Parenthood Alliance Advocates. I think, so I raised the question about the birth control patient. Just the way that this is written, I think you're trying to say is younger than 6 years old and one of these other conditions?
Right.
Okay.
Or if there's special needs and have airway problems, those are issues.
So
they're separate too, so they're not.
So if there is a patient, let's say, who's 15 years old and has a chronic condition, which could be broadly interpreted to mean all sorts of things, like obesity, perhaps would even be considered a chronic condition, would you then need to have a discussion with the patient's parent or guardian? I think you might run into all sorts of situations where providers wouldn't necessarily know what that means and when to involve a parent, which
Maybe
right
we
now,
need to remove chronic condition.
Yeah, that's a good point. That's too
I
vague.
think so. I mean, acne could be considered a chronic condition. And
Right,
if
or
you get,
depression or some other, I mean, really, yeah.
and
a
throwing the
backache.
parent into that discussion around birth control is fraught with problems.
So a question for Heather. That language was pulled directly from our established WAC 602. If we make that change, if we're removing that from the new rule, does that affect this old one?
I don't think so, because the 602 is dental offices, right? So we're not talking
Right.
about gynecology. So I think you can talk about whether or not you want to go into your dental anesthesia rule, but I think the dental anesthesia rule is mostly physicians going into dental offices providing general anesthesia. It's not a physician going in providing nitrous, right? So
Yeah.
it's more appropriate that the 602 has those considerations, because we're talking general anesthesia in those.
I just wanted to make sure.
Yeah.
Okay, so you're wanting to eliminate has a chronic condition?
Yes.
Yeah,
Or, okay. Does that fulfill what you are requesting, Rachel?
I think so. I think realistically, the special needs, you might run into some disability rights questions about whether those with disabilities would need parental consent for contraceptives, which may or may not raise constitutional questions, considering minors have a constitutional right to access contraceptives without parental involvement in Washington. But I think it's whether or not you think it's necessary for the health and safety of patients.
I think they pose extra risks, personally. You don't even know how that person with special needs will actually, as a teenager, respond adequately to the nitrous. They may need a full anesthetic, right? I mean, really, or mix of drugs, right? Nitrous
Yeah.
plus other stuff.
Yeah. I'm trying to think. I have done contraception, obviously, for many Down syndrome patients or whatever, what people with that type of sort of special need. Usually it's under general, and usually there is a guardian sort of available. But I could see where this gets sticky.
The problem is they probably should
but I'm-
go under general instead of this. That's the
Yeah,
whole
but-
problem.
Yeah. On the other hand, if you have a very high functioning person who has a diagnosis that, quote, qualifies as special need and is 16 years old and wants an IUD and, thinks that
But
you think they're fine for nitrous, is that okay then without having a parent or a guardian involved? It might be, right? So
I think it might be.
I think you have judgment.
I mean, I think that it's better being vague. I mean, that's what was said before, special needs. We don't want to get a list of what special need, what they are, right? It's a judgment. I think it just raises the flag that you need to think about as a
Yeah.
Physician wanting to use this, that there are potential problems in people who have developmental delay, right? I mean, we could say, I hate to use the word developmental delay there, but.
Right.
I think special needs is, again, broad and is
I mean, it
a
could be,
judgment call.
yeah, it could be like severe anxiety and they need their service animal. I mean, it could be anything. I like taking out chronic condition because that's too much like chronic medical condition. And yeah, too many. But I'm okay with this.
Great. I would
All right,
agree.
so we're good with 9.
Mm-hmm.
This is obviously misnumbered. I'll fix it later. Okay, so fix that one right now. Okay, so this one was something we talked about at the last meeting. Both 10 and 11 are misnumbered. There was an ask to include how the equipment needed to be cared for and things like that. So first we'll talk about 10, then 11, and then we'll move on from there.
Yeah, I thought those were fun.
Those are fine?
Yeah.
And then is 12 okay?
Yeah.
Yes, I think so.
Okay, so that's the end of our rule. I only included this stuff from dental
Oh, I see.
to see
That's why I was thinking of the dental, yeah.
Yeah, to see if you wanted to include any of this information. It's just this part is just informational. So I think we did
Do we
include
want
some
to
of
have
this, but
this charge? Do we put like this is the patient responsiveness, all that. What is deep sedation?
I think this is
This-
where we were talking about maybe having some sort of assessment for like stability for discharge from the office. I
Yeah,
don't know that we want it to be this involved and detailed, but I think that it was, I think Dee Bender made that point about like some sort of documentation of assessment of return to baseline and appropriateness for discharge. Is that?
yeah, I think we should have that. I think it would be vital signs, alert oriented, talk and respond to verbal questioning, sit up unassisted, walk with minimal assistance. Does not
Okay,
have
so
nausea, nitrous does create nausea. It doesn't ruin the atmosphere, contribute to global warming, but there are a lot of issues with this drug. The nausea, and if you want to go through that, which I think are important, I think the vital signs are important. Oh,
so you want to include
except for
one.
the pediatric. For adults, pediatrics.
But not this A, the ASA 1 and 2, not that.
Well, that's not required. Yeah, I mean, they don't need it. Most people,
Okay.
I mean, if the kid's up or the pediatric is uncooperative. Yeah.
Amelia, are you showing this on the screen? Is it just me? I can't see it.
Yeah, it's there.
Yeah, I
It's
am.
there. My
I just
view
highlighted
changed.
something.
Sorry, I had to re-sign in from my phone, so never mind. It's just me.
This time it was just you. Okay, so you want to include 1. Do you want to include this whole sentence? Pulse rate, respiratory rate? I mean, that makes sense.
Yeah,
but-
I think for adults, you really need it. I think for a
Mhm.
kid, you can, I mean, just say, skip maybe number 1 and then say a pediatric patient who's uncooperative or emotional, so it isn't needed. I mean, some kids may not, little kids may not like vitals, but I don't see why we just,
So you want this and then B? Don't want A, right?
yeah, I think we're talking about this nitrous and local.
Do you want C?
No,
Okay.
I mean, I think 2 needs to be there. 3, 4, 5.
Go down to 6.
6.
Seven?
I don't know if that's, I mean, it's not the anesthesia provider. What do you guys think? I mean, it seems fine to have that, right? Because the discharge, they want to document the discharge.
I can't see any of it anymore.
Oh, okay. It says
Read
the
it to me.
anesthesia provider has made a discharge entry in the patient's records. It's a requirement. These include condition on discharge, name a responsible party to a patient's release, and if required, released. I don't think we need that.
That seems like overkill.
Yeah. I would just scratch 7.
Okay, no
Vital
7.
signs, alert and oriented vital signs.
Yeah.
Stable.
So do you need 8?
No, I think so.
Okay, so that is it. So I will revise and add those things as whatever number is next. I think 4 is next. I can't remember. But now we'll go back, since we have a little bit of time, we will go back to this one, which is the physician should ensure the patient is continuously monitored throughout the duration of its administration by another healthcare provider. And then we had a licensed healthcare provider. And then we had this language that was in the chat that said the licensed provider administering the nitrous oxide must be a separate provider than the physician performing the procedure.
I think that sounds
Wait.
good.
Yeah,
Do you
that
like
seems
this?
quite
This better than
efficient.
what we have? Okay.
Yeah.
Yeah, it's more efficient. Yeah.
Yeah. It's not as clunky for
It's
sure.
clearer too.
Yeah.
Yeah.
Right.
Thank you. Thank you, whoever wrote that.
Why we have these meetings. Add this instead. Okay. Got it. All right. So, are there any more? I'm kind of taking over Dr. Domino's job here.
That's
The
okay.
next thing is
You know, you're
talk
better
about-
at it than I am. So, you know.
Are there any other questions or comments about this language? Obviously, we will hold another workshop. Doesn't look like there's any.
Okay,
I think we're
Amelia, you
making
can
progress.
go on the
Yeah.
next one. We're ready.
What was that?
I'll do the next section.
Hold on.
Are we ready?
Yes.
Next, we will
Yes.
review the proposed revisions to WAC 246-919-601.
Okay, let me pull
That is-
that one up. So all that one is we're adding in, hold on. What's my screen here? We're adding in the exemption and referencing. Hold on. Let me get there. Okay. Oh, wait, I made myself a little shortcut. There we go. Okay, so we're adding into 601, which is our established WAC already, the exemption and referencing this other WAC that we've been working on. So that's the only change we're making to 601. But I do need to make sure that this language is okay with you guys to present in the future when we move forward towards the CR 102, which will be a little bit, but I just wanted to get this one cleared so we don't have to keep revisiting it every workshop.
That sounds good to me.
Yeah, I think it looks good.
I
Okay.
can't see it, but if you guys are fine with it, I'm sure
Okay,
it's fine.
it says the using nitrous oxide under the requirements in WAC 246-919-603, which is what we've been spent the past hour and a half discussing.
Right.
So it just means that we can make changes there, but don't have to make changes to this office-based surgical settings
Right. Okay. Yeah.
document, rule,
Yeah.
whatever it is.
I read it all yesterday. I just couldn't remember exactly. Thank you. Agree.
Okay. So we approve that. So next we will review and address the written comments, starting with those that are posted on the Washington Medical Commission's website. Do we have to, I mean, we looked at them. Many of the comments, as we mentioned before, are talking, you know, are commenting about nurses. And we don't have any regulation authority over nurses. We only have regulation authority over physicians and physician assistants. And it's not written into the physician assistant, whatever they are, rules. So to use it, so it really pertains only to MD physicians. Again, we have no authority of DO physicians. So in terms of some of the other comments, not sure where I put all of them, but Do people have other things that we have to address? Do we have to go line by line?
No, so the ones that are, these, especially these first two that talk about ARNPs, obviously we can respond on the website and we can respond as part of the rules package later, because these are all part of the rules package now that they've been provided to us. And so we can respond to those. We don't have any authority over the folks that they're addressing. And then I've already responded to this one from Danny. I've already responded to it on the website. Basically just telling them that, we have no control over nitrous being sold. So that's not our job. And then there's this comment, which I think is also about ARNPs, the one from
Yeah.
Krista. So again, we can address that. We don't have any authority over them. And then this one is pretty much the same. It talks about physicians, dentists.
I mean, it does talk about the continuum of anesthesia, and we all know, or at least you should know, who do sedation that goes to mild to moderate to deep to general, and it's a whole thing. And people can go from one level to another, and particularly the ones that we worry the most about are ones who are older and have a lower level of, could be very well anesthetized by 50% nitrates, possibly, if you're 90 years old and you're ill. And the other thing deals with use of other sedatives. And I don't know if it was in there or not, but you shouldn't really have other sedatives being used. So that's what I
Right,
read
I think
there. I
that's
can't
in-
see it right now.
Isn't that in the rule already? We have it somewhere. You're not supposed to
That's what
use
I
this
thought,
with
but
opiates and benzos and things.
Yes, so that is in the
2B or something. Yeah.
It's in the opioid prescribing rules. There's no, I can pull it up if you want, but it's in the opioid prescribing rules and it talks about, let's see, hold on.
oh, I see. Nitrous in the beginning. It's used without another inhaled anesthetic, sedative, or opioid drug. So I think that covers it.
Yeah, it's
Yeah.
right in the beginning. Yeah, exactly.
It's right in the
Yeah.
beginning. I thought it was there. I
Yeah.
just didn't see it.
Yeah. And I think that's really important. So it's good that it's there.
And then, so I think we've addressed a lot of the things that were in this last comment from Kelly Camp as part of the language. And then we have the comment from Wisma. Billy, did we address this comment for you?
I feel it was sufficiently addressed. Thank you very much.
Okay. All right. So that's all the comments that we had received written.
Okay. Let's go back to, were there any additional questions or comments about the draft language from people who are participating in this meeting? I don't see anyone, Amelia.
No.
Okay. Good. Are there any questions from attendees that have not been answered?
Doesn't look like it.
Well, thank you all for your participation. Ms. Boyd will now discuss next steps and provide contact information.
Okay, so our timeline is pretty much still on this same track. This is the same timeline that I presented at the first workshop. We will try to hold the next workshop, which will hopefully be the final one, either sometime in November, maybe early December. If not, then it will have to wait until the first part of next year. And so will take a little longer to get those adopted. We do have I'm hoping to have this completed and ready for presentation to request the CR 102 at the January business meeting. So we'll see how that goes. And then, so that would be the next step, is just doing one more workshop, hopefully. And then we'll initiate the CR 102. And then if you have any additional comments, you can, I think you can actually, as a participant, click on this link. We do have a comment page for every rule we have in progress right now on our rules in progress page. Or you can send written comments to medical.rules@wmc.wa.gov, and they will be included in the rulemaking packet moving forward. And then if you just have any general questions about rulemaking, you can just contact me directly if you'd like.
Great. Well, is there anyone else who wishes to comment? I don't see anyone, but if there's no one else who wishes to speak, I want to thank everyone for all your very valuable feedback and comments. And I will now close the workshop. And on my time, it's 4:08 p.m. according to my computer. Thanks so much. Bye, everybody.
Thank you, everyone.
Bye, guys. Have
Bye.
a nice
Thank you.
evening.